Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds for Tuesday, March 5th. Welcome, everyone, today. This morning, we have an external speaker coming to us from the University of Ottawa Heart Institute. Dr. Emel Celiker Guler is a cardiologist, originally from Turkey, trained at the University of Istanbul, did her residency and fellowship at a major heart institute there that I understand has 3 cath lab rooms running 24/7 doing acute PCI and 18 operating rooms running all the time. So definitely got good experience. Yeah. In 2018, she moved to Ottawa to do an advanced cardiac imaging fellowship. And she's a true multimodality imager with training in PET, nuclear, coronary calcium, coronary CT angiography, and cardiac MRI. And today she's going to speak to us about that. So Dr. Celiker Guler, welcome, and I look forward to your talk.
Good morning, everyone. First and foremost, I would like to express my sincere gratitude for inviting me. It's truly an honor and exciting opportunity to be here among such esteemed colleagues and professionals. And also, I want to express a special thanks to Carrie and Kelly for organizing my meeting and their incredible help for my presentation. And furthermore, I'm deeply grateful to Dr. Robert Miller and Andrew Howard for providing me this opportunity. Thank you. And today I'm going to talk about navigating coronary artery disease challenges with cardiac PET, cardiac CT, and cardiac MRI. Let me share the summary of my presentation. I will briefly discuss the prevalence and cost analysis of coronary artery disease and why we need accurate diagnosis and management, and then continue with the underlying pathophysiology. I am going to talk about the roles of 3 state-of-art imaging techniques: cardiac PET, cardiac CT, MRI, and share some case examples and the MARC studies. I try to choose which has a significant impact in diagnostic accuracy and prognosis. It's hard to cover all the important studies. And first of all, cardiovascular disease, as we know, remains the leading cause of disease burden in the world. And the death rate has been decreasing in high-income countries because we did a really good job last 30 years, such as significant advancement in revascularization techniques and early diagnosis with advanced technique, prevention of sudden cardiac death. So, but there is a red flag. The age standardized rate has begun to increase where it decreased previously. And now let's turn our attention to Canada. In Canada, the prevalence continues to increase over time while the population grows. In 2012, about 2.4 million Canadian adults were living with ischemic heart disease, including approximately more than 600 with a history of an acute myocardial infarction. So what is the result to this to economy? In Canada, the cost associated with cardiovascular disease is estimated to $22 billion annually. Hospitalization costs increase with the number of affected arterial beds, almost 10 times higher if 2 or 3 vessels affected than hospitalization with only multiple risk factors. In fact, preventative measures are most cost-effective method, but at least if we will diagnose earlier, rapid and accurately and manage it before complicated, we could decrease the associated cost significantly. And what is the problem needs to be addressed? The problem we need to focus on is bigger than what we realized in the past 20 years. Coronary artery disease used to be mainly seen as stenosis in epicardial arteries. Now we understand better the issues affecting whole coronary circulation, including microcirculation. And microcirculation is crucial for patient symptoms and outcomes. And the coronary arterial system creates a network with various size segments larger than 400 micrometer to capillaries smaller than 10 micrometers. And epicardial arteries don't usually impede flow much. Their size adjusts according to shear stress and endothelial function. But on the other hand, prearterioles and arterioles control most of the heart's blood flow resistance based on heart's changing metabolic needs through the coronary capillaries. And also abnormal structure of macro and micro circulation are different histologically. Macrovascular system, where we see plaque, consists of lipids, inflammatory cells, smooth muscle cells, and connective tissue. And over time, we all know these plaques can become unstable and prone to rupture. And now advanced imaging methods such as CT imaging can assess the volume and the extent of atherosclerosis, and even we can identify vulnerability. However, microvascular remodeling does not include atheroma. It leads to microvascular obstruction with luminal narrowing of the intramural arterioles and capillaries. And with microvascular obstruction resulted increased resistance to blood flow. And we can evaluate both invasively and non-invasively. And non-invasively, PET, CT, and stress MRI are known, well-established imaging modalities. So what is the role of multimodality imaging? And has many roles in all steps. And start with understanding underlying pathophysiology, rapid accurate diagnosis, guide management, improve prognosis, and make care pathways more efficient and cost effective. I want to share a case from University of Ottawa Heart Institute, which shows how multimodality imaging can help to understand underlying pathophysiology even in complex patient. This is 58-year-old male with non-hypertrophic cardiomyopathy was reviewed in a clinic due to exertional chest discomfort. And chest pain in hypertrophic cardiomyopathy is often associated with outflow tract obstruction and microvascular obstruction rather than epicardial coronary arteries. But the patient underwent a high resolution PET scan during stress and rest condition. Okay, and the first row is stress and second row rest, and which reveals significant regional ischemia in the septum and moderate ischemia in the anterior and inferior wall. And follow-up CTA indicated just minimal plaque, build up, no major obstructive coronary artery disease, and PET CT image perfusion confirming a subendocardial ischemia, this patient. And a patient followed by hypertrophic cardiomyopathy, so had been conducted 2 months prior, cardiac MRI, and show a variable correlation between areas of reduced perfusion and the presence of fibrosis. So concluded that this variable correlation suggests that areas with more significant ischemia could potentially develop more fibrosis over time. And this case may show the potential role of microvascular ischemia in symptom development and fibrosis progression in hypertrophic cardiomyopathy. So after understanding the complex mechanism, and this leads us to naturally to this question, how do we diagnose it effectively? And this brings us the role of cardiac PET in our diagnostic arsenal. And first of all, cardiac PET imaging have many advantages over SPECT, and it has high resolution due to several factors, including detector with excellent sensitivity, improved algorithm in imaging reconstruction and motion correction. I don't want to go in details, but we have high resolution compared to SPECT, both spatial and temporal, and excellent diagnostic accuracy, and we can quantify absolute myocardial blood flow. And another advantage is lower dose radiation, both for patient and hospital staff. I'm going to start with high resolution. Is this just technical impairment, or does it really impact our patient care? And this patient, rubidium, first row rubidium PET scan, and the second technetium, and 52-year-old male, 3 months following PCI of the LAD. And percentin PET images demonstrate substantial residual ischemia in the LAD territory, almost some stress score 18. But it's same patient, I think 2 or 3 weeks apart, first exercise technetium was done, and that show same patient only milder ischemia, and probably due to lower tracer retention. When we compare to normal regions, and myocardial perfusion is a relative perfusion defect. And so in normal perfusion and normal areas, in PET is much more bright. So, and lower tracer retention and lower hyperemic stress compared to percentin PET affect our patient care significantly. We can easily say this is just a mild ischemia and follow up, but this patient revascularized after PET. So how do we quantify myocardial blood flow, and how do we get high resolution images? And the reason is ideal radiotracer. Ideal radiotracer for blood flow quantification should have several characteristics, such as high myocardial uptake and linear relationship between tracer uptake and blood flow over a wide range of flow rates. Water label oxygen is the optimal one, but it's not FDA approved. In North America, we use ammonia and rubidium. But when we look the SPECT radio tracers and the lack of linearity between uptake and high flow, that called roll-off, especially at high flow rates, that explain in part why we have relatively low sensitivity in SPECT images, and especially in intermediate severity. How do we quantify blood flow? It requires two-step process, and radiotracer is injected while at rest, and baseline uptake of tracer in the myocardium. This reflects resting myocardial blood flow, normal range between 0.6 to 1.3. And during peak stress, another dose of tracer is administered, and uptake of tracer during stress reflects stress myocardial blood flow. And normal is considered higher than 2. And it depends age. And if you are looking young woman with systemic disease, your target is 2.5. And other parameters, coronary flow reserve or myocardial flow reserve, this defined as the ratio stress to rest, and normally it should be higher than 1.5. And this is reflecting adequate coronary vasodilator reserve. Okay, we quantify blood flow, and how do we use it? Does it really important? And there are many clinical scenarios. Quantification is likely changing the clinical interpretation. First is multivessel disease. We are suffering and other imaging modalities, or revascularized patient and balanced multivessel ischemia. And at the same time, we are able to assess microvascular disease in two. And I'm going to share some cases from a practical guide for interpreting, reporting cardiac PET measurements of myocardial blood flow and information statement. I had a privilege to being part of this dream team. And first study, 49-year-old woman, and presented with exogenous chest discomfort, and risk factor is dyslipidemia. And perfusion, normal perfusion, rest, stress, and MFR myocardial blood flow, rest normal, stress is higher than 2.5, and reserve is higher than 1.5, and no coronary calcium. Okay, what is the teaching point? This is just normal rubidium study. And teaching point, we exclude definitely epicardial critical lesion, but at the same time, what we exclude? We exclude left main disease is not questionable, or extensive coronary artery disease is not questionable for this patient. Microvascular disease is not questionable anymore because there is a good response in stress and good flow reserve, and always questionable for nuclear studies, non-response to vasodilation. There is significant response because we see how blood flow augment in stress. Other case, a 72-year-old woman with angina and no response to medical therapy. Perfusion is normal, and if we have just perfusion, it's normal. But let's look rest, normal flow. But stress, there is no significant augmentation in all three coronary territories and global MFR2, and reserve also reduced. And there is significant coronary calcium. Even though perfusion is normal, this is high-risk study. And this patient referred for CAD and had a history of 3-vessel CABG. Another case, it also helps us to understand better and multi-vessel disease. And this patient, 52-year-old male with history of lateral wall non-STEMI and presented to clinic with recurrent angina. And stress imaging showed moderately reduced tracer uptake in the entire lateral wall with improvement at rest, which consistent with moderate size region, moderate ischemia, and primarily LCX distribution. And this patient has lateral wall ischemia and probably no urgent coronary CAT referrals. But when we look to flow is significantly reduced on all 3 vessels, and reserve is reduced too. This is high risk. So we refer this patient, and this patient has 3-vessel disease. And my last example, 72-year-old woman has a history of exogenous dyspnea and long history of poorly controlled essential hypertension. This is risky for microvascular disease. Perfusion is normal, but flow is abnormal stress and reserve. And a calcium score, yeah, I couldn't find it, but calcium score was reported 2 for this patient. And the presence of low calcium score in the setting of abnormal MFR generally suggests microvascular disease rather than epicardial coronary artery disease. But we generally suggest invasive hemodynamic confirmation. So what is the role of PET in microvascular disease? Based on a 2021 ACC guideline, if we suspect INOCA, next step, non-invasive or invasive tests. Non-invasive tests are more prevalent, invasive one more comprehensive. Cardiac PET and stress MRI class 2A indication and stress echo class 2B indication. Stress different than PET and MRI. Stress echo show generally speaking, it's just a lady territory, not global or 3 territories. And reduce MFR, even an ischemia or not, and diagnostic criteria for microvascular disease. Why it's really important? And a systemic review, including 79 studies, and show that reduced coronary flow is strongly associated with increased risk of all-cause mortality and MACE across a wide range of pathological process, HFpEF, acute coronary syndrome, Takotsubo cardiomyopathy, or just microvascular disease. And this finding supports recent recommendation that coronary flow should be measured routinely in clinical practice. And this helps us to target aggressive vascular risk modification for individuals at high risk. And let's go back to PET, and PET has excellent diagnostic accuracy. This is the first head-to-head comparison. Compare PET, SPECT, CTA in diagnosing coronary artery disease, and a single center study including 208 patients, and all patients underwent initial invasive coronary angiography. We show 44% had hemodynamically significant CAD, and then all patients received non-invasive imaging. And compared to these non-invasive results, and investigators showed that cardiac PET was significantly more accurate for diagnosing ischemia as compared CTA and SPECT. And another strength of PET is also have an incremental role in prognosis. This is one of the first prognostic studies conducted at University of Ottawa Heart Institute, almost more than 10 years data. And study question was prognostic value of MFR and patient assessed for ischemia, and including 704 patients, single center study, almost follow up more than 1 year. And we grouped the patients in 4 different categories. And one is summer stress score normal, MFR reduced or normal, and summer stress score higher than 4, MFR reduced or normal. And the study showed that patients with impaired MFR had a higher incidence of cardiac events and MACE at approximately 1 year follow-up. And MFR improved risk stratification in patients being assessed for ischemia. And a recent study, including many studies, more than 10,000 patients, showed that every 0.1 unit decrease in MFR was associated with a 9% greater hazard of all-cause death. Another advantages of PET-CT, at the same setting, we are able to assess for coronary calcification, and coronary artery calcium offer both, we know, prognostic and clinical benefits. I want to share this study, and including 706 patients. A patient doesn't have any history of coronary artery disease. They look just normal rubidium PET study. And 61% of patients have a coronary artery calcium score. That means more than 60 patients have subclinical atherosclerosis. Why it is really important? Because identification of coronary artery calcium influences subsequent physician prescribing pattern, such that those with coronary artery calcium score are more likely to be treated with proven medical therapy for the treatment of coronary artery disease. Key point for cardiac PET. PET perfusion, excellent diagnostic accuracy. Measuring blood flow with cardiac PET doesn't increase radiation or imaging time. MBF assess entire coronary delivery, including epicardial and microvasculature, and also both MBF and at the same setting coronary artery calcium score improve diagnostic and prognostic assessment, so does impact our patient management. While PET offers us unique insights, now I want to focus on another powerful imaging modality, the cardiac CT. And this graph shows the utilization of CTA after introduction of coronary CTA funding in Ontario. There has been increase in, and really it's a peak, the use of coronary CTA. And why is CTA so popular? Because it's non-invasive, and we get accurate images of coronary anatomy in just 2 minutes, and additional surrounding tissue, aorta in many places at the same time, and fast acquisition time. And technology has been sophisticated last 20 years, and cardiac CT introduced 70s, and now we are able to acquire images one single heartbeat. And Cardiac CT Society work really hard and get really nice data, and published article rate is much more higher than other imaging modalities. So what is the diagnostic accuracy? Did many studies reference as the invasive coronary angiography and show sensitivity is really high, but specificity is low, and it tends to overestimate the severity of stenosis compared to CAT. That means increase inappropriate referral to CAT. And also even they compare with FFR, and sensitivity was still high, and specificity is a variable, and generally speaking, it's low. And so what happened after these 20 years? In 2012, cardiac CTA just class 2B indication, and able to exercise patients, unable to exercise class 2A indication. But what about 2021 ACC chest pain guideline? For intermediate to high risk patient with stable chest pain or no known disease, or with acute chest pain, no known disease, class 1A indication, highest indication. And even patient has previously abnormal stress, class 2A indication. And we all know that normal CTA exclude coronary artery disease, and we usually refer low to moderate or now intermediate to high risk patients. And we are now discussing going to CAD without initial CTA can be a question, because in women, initial CTA was associated with a lower frequency of major procedure-related complications compared to initial invasive coronary angiography. And in men, CT as the initial CT was associated with lower risk of expanded mass composite. But I mentioned before, CTA tends to overestimate the severity of stenosis, often because of coronary calcification that appear larger than their actual size due to blooming artifact. And what SCCT guideline recommends, if you see moderate stenosis or even 70 to 90% in one or two vessels, second step, functional assessment, either with FFRCT or stress imaging PET or SPECT. For CT-FFR can improve CTA diagnostic accuracy, positive predictive value, and decrease inappropriate referral to CAD. And how do we acquire images? Routine CTA images data are received, and then quantitative three-dimensional anatomical model is generated. And then physiological model of the microcirculation is derived from patient-specific data based on articles, but main principles, but I don't want to get in details. And finally, physical laws of fluid dynamics are applied to compute coronary blood flow. And we get images. Many studies show increased diagnostic accuracy, but there is a limitation for FFRCT. If your images are not good enough in cardiac CT, you cannot get good FFRCT results. And now only one single vendor is available. That means cost. And on-site is promising, hopefully. But today I'm not going in details FFRCT. I think the most powerful role of cardiac CT detection of non-obstructive disease and plaque assessment is now very popular and promising. We can assess plaque quantitatively, qualitatively, but just briefly talk about qualitative assessment. Why is really important plaque assessment? Because all other stress imaging modalities assess for critical or hemodynamically significant stenosis. Different than other images, cardiac CT provides grading and detection of non-obstructive disease. That means the patient who receive a correct diagnosis, patient presented clinic and order stress test, and I say normal, and probably patient have no motivation to implement healthy lifestyle or get the enough medication. And this was compared, is really nice study, compared to functional testing to coronary CTA in stable patients. And coronary CTA was associated with greater use of statin and aspirin than functional images. And also patients who receive correct diagnosis are more likely to receive appropriate preventative therapies and may have greater motivation to implement healthy lifestyle. And Scott Hart investigators showed that in addition that patient gets enough medication. So, and this patient has much more less non-fatal myocardial infarction compared to standard care. And we are able to assess plaque. This is more than a prognosis. And besides that, as I mentioned, quantitatively assess extent volume. but this is another 1 hour talk. So I only mentioned qualitative assessment and characteristic indicating high-risk plaque, including positive remodeling, napkin ring sign, and spotty calcium and low Hans failure. And this napkin ring sign is almost same like IVUS necrotic core. And why is really important? That study is in Romikatu study. And investigators aim to assess the predictive value of high-risk plaque features identified in CTA for acute coronary syndrome. The study population, including 1,000 patients presenting with chest pain to emergency department, and initial assessment does not suggest MI or ischemia, and all patients underwent cardiac CT within 24 hours. And primary outcome was acute coronary syndrome. And study demonstrated that patients with significant stenosis, as we expect, were 34 times more likely to have acute coronary syndrome. But similar to significant coronary artery disease, also patients with at least 1 or 2 high-risk plaque, 32 times more likely to have acute coronary syndrome. And all high-risk features were found associated with acute coronary syndrome. And they did multivariable logistic regression analysis and adjusting the clinical factors and significant stenosis, and still high-risk plaque was associated with acute coronary syndrome. And now ACCT guideline recommend adding V, vulnerability, if we see more than 2 or more high-risk features in cardiac CT. CTA key points: fast, safe first-line imaging modality. Performance is a gatekeeper for invasive coronary angiography. That means increase the ratio of interventional to diagnostic procedures, and plaque features are promising, amazing, and independent predictor of acute coronary syndrome. So I'm going to talk about role of CMR. I know this center is expert. It's hard to talk about the role of CMR here, but briefly, I want to mention. First of all, why cardiac MRI offers. Cardiac MRI offers gold standard for volume and function assessment, and also provides superior myocardial characterization and edema, infarct, microvascular obstruction, hemorrhage, and also current CMR imaging strategies for perfusion and viability assessment has widely accepted. And we can assess for thrombus and MINOCA, and stress imaging is possible to detect inducible ischemia. Even we can quantify blood flow now. And as I mentioned, it's really diagnostic and prognostic value. And what is the recommendation? In acute chest pain, chronic stable chest pain, cardiac MRI almost comparable all imaging modalities, and suspected MINOCA as a specific CMR recommendation because provides high characterization. And when we look the Europe data, it's almost 10 years data, Euro CMR registry, but I really like because cardiac MRI has significant impact on patient management, both new diagnosis and therapeutic consequences, especially assessment for myocardial disease, ischemic viability. And after that, and second, test referral is really low. It provides all aspects of cardiac function and tissue characterization. And this is my patient, and patient presented with late anterior MI. The question was pseudo or true aneurysm. There were 2 questions for this patient because patient had high risk diabetes mellitus and presented with acute heart failure, increased creatinine. So echo show aneurysm in apical region, and 2 questions. First one is this pseudo or true? And the second one is patient had really high risk anatomy. So second question, if we do aneurysectomy and revascularize this patient, these walls are viable. And first, past imaging suggests thrombus, filling aneurysm, and this is a true aneurysm, wide neck, and and okay, and transmural infarct in apex and apical regions. But when we look other walls, just the mild late gadolinium enhancements suggest viability in mid to basal segments. And I think my time is limited, but I want to talk about briefly stress MRI. You know well, it has high resolution, no radiation. BMI is not limitation. And I really like these images from Lancet 2003. It's an animal model tissue staining. And CMR identify almost 92% of segments with subendocardial ischemia, but SPEC identify only 31. And how are the images acquired? I don't want to get on the details, ischemic stress testing, but general principles apply. And contrast injected, both rest stress, then high resolution rapid acquisition are obtained, show contrast bolus going through RV, LV, then enhancing myocardium. And even we are able to assess for quantitatively now, like PETs. And many studies, but this is the first prospective trial, and show stress MRI has significant sensitivity and negative predictive value compared to SPECT images, and almost same specificity and positive predictive value. Another important finding that I think for this study, even it's still highly sensitive in 2 or 3 vessel disease, sometimes SPECT suffers, we know that. And this is the recently published head-to-head comparison CMR to PET. It's important because, yeah, it's the 3 Tesla CMR against cardiac PET rubidium, and prospective multicenter randomized controlled trial. All patients underwent CTA, and then critical patients refer both CMR and PET. And main results, both PET and CMR have similar sensitivities and specificities. Moderate sensitivity is around 64, but specificity is high, 85%. And overall, a PET diagnostic accuracy is higher than compares CMR imaging. Probably in here, there is no quantitative assessment for CMR. And why it is really important, because it's the first second line ischemia testing. We test all these studies as a first line for diagnosing, and second line, and limited evidence, and similar diagnostic performance. PET accuracy is slightly higher. Higher specificity of PET and CMR may be favorable. I want to argue about that because sensitivity is low when we compare first-line imaging modalities. Why? And even this patient has obstructive disease, and we expect to see higher sensitivity because clinicians know. But probably our reference method, FFR, still not really reference, and all these FFR results is around 0.81. And CMR also has significant prospective prognostic role, and show single center study, and patient with follow for 5.4 years, and primary outcome was cardiac death, and secondary outcome was non-fatal MI. And primary outcome, and no ischemia, no LGE, and LG is persisted throughout follow-up. So key points overall: MBF quantification of coronary calcium with cardiac PET provides crucial diagnostic and prognostic information in both micro and macrovascular disease. CTA, non-invasive first-line imaging modality, characterize disease burden, and MRI has high spatial resolution and allows precise detection of ischemic areas, viability assessment, scar tissue characterization, and also help us to risk stratification and treatment planning. Thank you so much. And I want to share Sir William Osler, Canadian physician who shaped the modern medicine, once said, "Medicine is a science of uncertainty and art of probability." In the context of our journey today, these words resonate profoundly. As we explore today, no single imaging modality offers one-size-fits-all solutions, and each modality has its own strengths and limitation. And I think this diversity is not a drawback, but a testament to the complexity and individuality of patient care. Just as Osler highlighted, our role as a clinician is not just to gather data, but to interpret it wisdom, balancing probabilities, and navigating uncertainties. Thank you so much. These people contribute my life journey significantly, my Ottawa University and Koch University family, and these are my family, my supportive husband, and my amazing sisters. They are physicians too. Thank you. Yes, I took this photo.
Thank you so much. That was a wonderful talk, great overview. So we'll open the floor to questions. Anyone in the room? Oh, Mike's, thank you. Or online, people can just speak up, or we'll open the chat box and people can online can answer questions that way. Any questions in the room? I have
Is it
one.
okay if I ask?
Oh, go ahead, Rob.
Yeah, so great talk. Thanks for that. I guess it's just a simple question. So you showed a case where the myocardial blood flow was low, but the calcium score was 0. How do you differentiate like non-response to pharmacologic stress versus microvascular disease?
Okay, this is really great question because this patient had another stress imaging, and the second one show almost same results. And we and also we can look splenic shadow and some details, and still same results, and we confirm with invasive hemodynamic measurements. Thank you.
So I have a question for you. So Rob Miller is always pushing me to start a PET program here. And get that program. You know, we have multimodality imaging. What is the role of a PET program in a sense?
Okay, yes, why it's really important. And when we look at data, patients are aging and much more patient presented with microvascular disease, not only women and also male too. And PET offer us a gold standard for MBF quantification. I think the most strongest part is that. And in the same setting, we can see calcium score, we can assess for epicardial and microvascular disease, which is really important. Now we know that it can be seen in context of obstructive disease, cardiomyopathies, and just cardiac syndrome X. We previously in 1990s, we defined like that, but much more patient presented. And I think cardiac PET offers us to differentiate this patient, diagnose this patient, and start management.
I'm going to take that question a little bit further. In an era where funds are getting tighter and tighter, and if you decide to go with PET imaging, is there a particular program that you can eliminate to save money?
Okay, for PET imaging, it's really expensive compared to, and even in camera, when compared to SPECT imaging, one is 3 million and other one 5K. And radio tracers are really expensive compared to other. And fluoropredas promising. I hope it will be much more affordable than rubidium and ammonia. And when we look the area, in SPECT, well established, no prognosis is perfect imaging modality. It can, but in this is Calgary University or Ottawa University. At least these programs have to get an access this state-of-art imaging modality. Of course, it's not for every patient or everywhere, and you have to get enough volume to get the cover money you spent. But I am thinking that if you are really want to be strong in all imaging modalities, PET is one of the must.
Any other questions online? One came in on the chat from this week.
Can PET scan assess accuracy the size of pericardial effusion? Then estimate the size of effusion. Pericardial effusion and a cardiac CT is low dose cardiac CT. Maybe talking about that. Cardiac CT is low dose cardiac CT. We can get pericardial effusion. Generally speaking, no contrast cardiac CT. I can say just that.
Questions in the room or online?
I had a question, if I may, Emel, very nice talk, Pacific Academy here. I was just hoping you could comment a little bit about myocardial blood flow assessment with CZT spec. I think you may have done some work on that and how it compares to PET myocardial blood flow and if you think it's ready for prime time.
Okay, and first of all, it's really promising, and we University of Ottawa Heart Institute get first results in SPECT CZT myocardial blood flow and validated. And why it's really important, as I mentioned before, PET is not affordable for all over the world, and only 0.3% nuclear imaging is cardiac PET. But in cardiac CT everywhere, CZT camera is has better sensitivity, and so with using different kinetic modeling, we are able to assess it. But I was not the part of that team. Now we are trying to develop SPECT CT myocardial blood flow. Hopefully, talk about next year.
If there are no further questions, we'll close the session and thank everyone for coming.
Great talk. Thanks for coming.
So that's my thing.